nutritional, but more importantly, its immunological benefit to the infant or the child. Providing exclusively human milk to infants for at least 3 months of life actually has the potential to reduce the risk of infant mortality by up to 38%. And that extended milk expression also has innumerable benefits to the lactating person as well. Some other topics that you might want to go over in the postpartum session: how long to pump. Each pumping session should be a minimum of 15 minutes and a maximum of 25 minutes per breast. Pumping longer with no breaks, so somebody who wants to make more milk and decides to pump for an hour, that's actually not going to make us more milk. It's just going to make us sore. So maximum 25 minutes. Some tips for increasing output. I mentioned earlier that our babies are a huge factor in milk expression. And this is because thoughts of baby, baby sound, baby smell actually helps to release the hormones needed for milk expression. If mothers are permitted pictures, then we want to encourage her to look at them, to talk about baby while pumping, if that makes her feel relaxed and happy. Alternatively, if mom's stressed, overly concerned with how much milk that she's able to produce, this can actually limit her ability to express milk. We want to encourage moms to take those deep breaths. This actually assists our physiology, to close their eyes if they feel safe doing so. And really try not to focus on how much milk is in the bottles. Doing some hand expression, some breast massage kind of before or during pumping can also help with this. In regards to milk storage and pickup, one of the most important things to note about human milk is that it's not a biohazard. So breast milk really has more protective factors for humans, and that's like adults and babies alike, than it does inherent dangers. And so because of this, human milk can be stored really easily and safely in shared refrigerators. Although breast milk is a raw food, it's surprisingly stable. So breast milk can be stored at room temperature between 4 to 8 hours, depending on conditions, right? So if it's really, really hot in the room, we're closer to 4 hours. If it's nice and cool, we're closer to 8 hours. It can be stored in the refrigerator between 4 and 8 days, and it can be stored in the freezer between 6 and 12 months. So what's going to be vital to pumping parents who are incarcerated is that when storing pumped milk, someone needs to be responsible to write parent's name, the date that the milk was pumped, and of course the amount on the milk storage bag. So this is to ensure that there's no confusion regarding who the milk came from and when it was first expressed. Additionally, the safest place for pumped milk that's going to be transported within the week or the month to baby is actually in the main compartment or the back of the main compartment, not the door of a high quality freezer. We need to ensure that this freezer has a temperature, can get down to 0 degrees Fahrenheit or negative 18 degrees Celsius. It's going to be essential that mom can identify someone who's willing and able to actually pick the milk up on that weekly basis. This person should bring with them a cooler or ice packs. Breast milk can actually remain in an insulated cooler for up to 24 hours, so long drives are not an issue. However, it's important to note that if breast milk is frozen, just like frozen meat, if it begins to defrost, it shouldn't be refrozen. So instead, it needs to be then placed in the refrigerator to unthaw completely, and then needs to be used within that 4-day period. And lastly, of course, if a parent is supporting their supply through pumping and hoping to nurse baby directly, either during a sanctioned visitation or upon release, it's really important to discuss ways that they can work with baby's caregiver to help make this an easier process. So certainly if mom has time to spend with her child during visitation hours and direct breastfeeding can be facilitated, this would be really the most benefit to the dyad. In addition, caregivers can be taught to do something called paced bottle feeding or this paced method of feeding that more closely mimics the pace of breastfeeding. And this will help infants to transition with greater ease from the bottle to the breast. In order to facilitate paced bottle feeding, babies need to be fed, number one, an appropriate amount for their age and then for their size. They need to be fed when they're hungry, not on a schedule. This is very important as well. They actually need to be sitting up while being fed with the bottle held horizontally instead of vertically. So we're not pouring milk into baby's mouth. Instead, we're letting the baby take the nipple into their mouth and dictate the pace of the feeding, which is going to include those regular pauses that we typically see at the breast. A paced bottle feeding will typically take anywhere from 10 to 20 minutes, which is very different than when we pour the milk into baby's mouth non-paced. And then, of course, we need to recognize when baby's full, so teaching those signs of satiety and when the baby stops sucking, to remove that milk. We need to make sure that we're teaching that babies don't actually need to finish their bottles all the time. So here's just an image for you. Again, we're going to be giving you a handout that can actually be given to parents, both to moms and then as well to a caregiver, that includes tips on paced bottle feeding, includes tips on milk storage guidelines, so that can be happening in prenatal conversations when we're identifying someone who may be picking up breast milk to be given to baby. And of course, now we've covered kind of the basics of supporting lactation during separation. We actually need to leave just a little time to talk about supporting those that deliver and then choose not to provide milk to their infants. So lactation is so hardwired in our biology that even if a parent chooses not to pump and provide milk to baby, they're still going to experience a period of time where the body was going to produce milk. And without proper management, this experience can be painful and potentially a health concern. So as you learned when baby's born, that body has colostrum in small amounts. However, after the delivery of the placenta, there's going to be this sudden drop in a hormone called progesterone. And then there's going to be this really steep increase in another hormone called prolactin. And that's going to signal this onset of copious milk production. And with or without baby, this can lead a lot of moms to experience anything from just mild fullness to an extreme engorgement, which is that exceptionally painful swelling due to that increased interstitial fluid and milk buildup in the breast. If this is not properly treated, engorgement can lead to plugged ducts. It can lead to mastitis, which is a breast infection. It can possibly even lead to breast abscess. So luckily, you've already learned this wonderful first line of defense for treatment of engorgement, and that's hand expression. When treating engorgement with a patient that has no intention to continue lactating, it's important that we focus on comfort as the goal. So remember that frequent and thorough milk removal is what signals the body to make more milk. So if we want to stop making milk, then we actually want to only hand express to comfort. So just enough to relieve that feeling of fullness, but we don't want to completely empty the breasts. Otherwise, we're going to be perpetuating the issue. So cold packs and over-the-counter pain medication can be used safely to treat discomfort, as well as providing adequate support to the breasts, which again are going to be full and heavy and can possibly exacerbate the issue. Symptoms of engorgement, they really should only last for a few days. They should completely resolve within a week from onset. In the meantime, it's going to be really important to monitor our patients for any signs of infection, including your fever, your chills. If we have pronounced redness, it's usually just in one breast, not bilaterally. If there's a perpetual hard spot or an area that won't soften after milk removal or with some massage, and really any other general flu-like symptoms during this period. These are all signs that we could have a possible breast infection. And that, of course, is probably going to be needed to be treated with antibiotics. So those are the basics. I hope that was a good introduction for some of you. It might have been review for some others of you on supporting lactating people when they're separated from their infants. Of course, there are always going to be nuances that general education will fail to cover. And in those cases, I really can't recommend enough having a lactation specialist on staff. As an RN, as an NP, if you're a case manager, even officers, you can actually train to become lactation education specialist. This is a hands-off position providing education. It really goes into depth on how to best support lactation for those in your care. If your facility has access to an international board certified lactation consultant, even better. IBCLCs are really trained to work very closely with MDs and NPs to support lactating people and really address some of those more advanced cases. If you don't have one, we would also love to help to set up a pump and pickup program, which would help facilitate getting the milk from your facility to the homes of our little ones. You can contact me directly. That's my email address if you're interested in partnering on this project. I don't currently know of any such service that exists in Los Angeles County. Perhaps Saida or Aditi knows of something, but I have not yet heard of anything. If you're a medical provider,
No, I have not either, Saida.
Okay, thank you, Saida. Yeah, so this would be something that I think would be really a game changer in making sure that we have consistent pickups happening. If you are a medical provider, so it might be important for you to know where to source information about transmission of certain medications into breast milk. The world's foremost scholar on this subject is named Dr. Thomas Hale. His book is called Medications and Mother's Milk, and it was recently updated 2021. He's released an app which makes it really, really accessible to providers. You can really pull it up on your phone and search through some of the medications. And I'm going to give you a hint here on this. Most medications, the vast majority of medications, are fully compatible with breastfeeding. And that includes medications to assist folks in recovery. If it's not compatible with breastfeeding, usually there is an easy pharmacological substitute that is compatible. Some other additional reliable online resources. We have Kelly Mom, got great brief articles that are very accessible. The Academy of Breastfeeding Medicine is a group of physicians that have come together to put together protocols and research on breastfeeding and its interactions with a lot of other issues that we see. So if that's something that you're interested in looking at, La Leche League also has a lot of articles available online. And last but not least, your task force, the task force for infant feeding for the greater Los Angeles area, Breastfeed LA, and we have our website right here. So that concludes my portion of this. I do want to leave a little bit of time for some Q&A. If anybody has some questions that are specific, I can stop this now. Questions that are specific to lactation management. Feel free to unmute yourself.
Okay. This is nurse practitioner Harris here at CRDF, and I take care of the OB-GYN and patients here. You mentioned something about that they should have access to a mechanical or electric pump. Is that a law or that some kind of thing? Because we don't have that here.
Yeah, so actually, Aditi is going to be going over the new laws in our next section. So I'm going to hold off on your question then, and then we will discuss it. But yeah, that's a huge barrier in continuing lactation during separation. As you can imagine, we talked about hand expression, and it's a great way of being able to jumpstart lactation. But reality, for those of us on the line, if I said to you, every 2 hours for 10 minutes to 20 minutes, I want you to, squeeze on your arm and not stop squeezing. over and over and over again for 20 minutes every 2 hours, the reality is you wouldn't do it. I wouldn't do it either. So when we talk
Yeah,
about
sure.
lactation, it's not really an option, right?
Right.
We have access to, do you have access to manual pumps at your facility? So
Yes.
that's, you do. Okay. So that is possible. Again, that is incredibly tiring when you think about it. And so it also, you know, the double electric will have a motor in it that's really designed for when there is mother baby separation. So that's the ideal.
Right. I agree. Okay. Thank you.
Yeah. Thank you. Okay, so if you have other questions, feel free to put them in the chat as we go. I know that a lot of questions here are around implementation. So what we're going to do is we're actually going to go ahead and take a break until 10 o'clock. At 10 o'clock, we'll come back. We'll hear from Aditi on some of the model policy and laws that are passed and where we stand with all of that. Okay, so we'll take a 15-minute break. I'm actually going to mute myself and come back at 10 o'clock.
Hello, everyone. So it's 10 a.m., so I think we can get started again on my piece of the presentation. Again, just for folks who joined after, I think there are a few people who joined a little bit late. My name is Aditi Fruitwala. My pronouns are she and her, and I'm a staff attorney with the ACLU of Southern California. I was part of the team that helped pass the pump and pickup bill in California. So I'm really excited to get, this is sort of the dream that we have, that once we pass a bill, we actually get to talk with the people who implement the bill, which is all of you. And so it's really, really like a dream to be here and get to talk to you. I am also pretty new to giving Teams presentations. I've been in Teams meeting, but this is my first actual presentation. So please bear with me. There might be some hiccups here. And the other thing I wanted to say is that, oh, sorry, I'm seeing some activity in the chat. No, okay. One thing I just wanted to say is that my piece of the presentation is going to be on kind of what the law and policy is on paper. We'll review what AB 2507 requires, and then what sort of best practices are, and what we would recommend that the model policy be. But again, all of that is on paper, and you all are really the experts on how it works on the ground. And so I'm hoping that, at the end of this presentation, and maybe even at the end of Dr. Saida Pepra's presentation, we can have kind of more of a conversation about the type of issues that you're facing, and what we can do to help. We are definitely here as a resource, as Hannah said, to help implement this incredible law that we have in the best way possible, in a way that works for the work environment that you're in. So I'm going to start us off with sharing my screen. There we are. Sorry, I am new to all of this. Okay, here we go. For some reason, it is not. It's not letting me share. Oh, there we go. Okay. Are you all able to see the PowerPoint presentation? If so, can I just get a verbal yes on that?
Yes, we are.
Perfect. Thank you so much. I very much appreciate that. I can no longer see the chat. Okay, so I'm here to talk about reproductive justice at CRDF and jails in general. I want to give a quick note on language, which Hannah also talked about, that in this presentation, I'm going to say women's jails, women's prisons, because that's really the data that we have. And when we pass laws in this space, oftentimes those are the words that we use. But you all know that when we say women's jails and prisons, what we mean is we are inclusive of all the people that are incarcerated in those jails and prisons, which includes women, non-binary people, and transgender men. Okay, so first I kind of want to start us off with a very brief review of who we're talking about when we talk about people in women's jails and prisons. And the reason I want to start with this is I know that you all, this is sort of, for many of you, you already know this, either because you've seen this data and or because just anecdotally, this is the work that you do. So this is this is reflected in the population that you served. And so many of you know this, but I kind of just want to quickly just go through it just so that we're all on the same page. So when we're talking about helping, incarcerated people in women's facilities, we know exactly who we're talking about. And the particular issues that they face that other people may not. The first is that the U.S. incarcerates more women than any other nation. The data the graph that I have here is specifically for NATO countries, but that's actually now true for any nation in the world. We incarcerate the most women, and that number is growing. Since 1980 to 2019, which is the last year that we have data for this. our incarceration rate has increased more than 700%. And the reason that I wanted to kind of start with this is that you may all have seen just in your work that there have been more laws passed recently related to women's jails and prisons, and specifically reproductive health care in women's jails and prisons. And the reason is because the population is exponentially increasing and the law is just trying to keep up. And so you have seen and likely will continue to see more laws passed in this space as, jails and prisons have historically been created with only men in mind and men's needs in mind. And now as we're kind of understanding that women are incarcerated, but also incarcerated at a higher rate than even men are being incarcerated now, there's going to be kind of more requirements put in place for women's jails and prisons. So the folks in women's jails and prisons are, and I want to go through just a couple of demographic points here, more likely to live in poverty. So as you can see, for incarcerated people, 72% of incarcerated people, prior to incarceration earned $22,500. And for non-incarcerated people, that number is 48%. So that is, a massive, massive gap. So incarcerated people are more likely to have lived in poverty before their incarceration. They're also more likely to be people of color. 88% of the number of men and women incarcerated in state and federal prisons per 100,000, 88% Black, and Hispanic 65%, whereas white is only 49%. The reason that this is important, both for poverty and race, is that these populations have poor health outcomes and just more discrimination and bias in the healthcare system already, even before they're incarcerated. Same for LGBTQ and non-binary people. LGBTQ and non-binary people are 3 times more likely to be incarcerated. 33.3% of people incarcerated in women's prisons identify as lesbian or bisexual. 16% of all trans people have been incarcerated, and 47% of Black trans people have been incarcerated. And same is true for people with disabilities and substance abuse. 53% of people in women's jails have medical issues, 32% have serious mental health issues, and 82% have drug or alcohol abuse or dependence. So the reason for all 4 of these demographic points, the main thing I wanted to kind of highlight here is that these populations, even before they get to CRDF, are already facing barriers to healthcare that other folks aren't facing. They already have poor health outcomes. And that also rings true with breastfeeding and lactation. These populations are they're less likely to be breastfeeding their child because of the various structural barriers in the medical system that they face. And so, as y'all know, they're already, it's already a more vulnerable population. The other thing that's very relevant to this law and implementation is that 80% in women's facilities are mothers, and the majority are primary caretakers. And so incarcerating this population in particular also impacts their children, their minor children, and then obviously, as we're talking about here, their infants and toddlers. So I got started with this issue several years ago. In 2016, the ACLU of Southern California and the ACLU of Northern California did a pretty extensive look into what type of reproductive health care barriers folks were facing in California jails. So we went into jails, several in SoCal, several in NorCal, and interviewed people directly and said, what are the types of things that you're experiencing? What are the healthcare needs that you have that maybe the jail isn't providing because it's not required to provide? Kind of what are the gaps between what you need and what the law requires? And we actually expected to hear a lot about abortion. That's sort of what we hear about on the outside, a lot of, gaps in abortion care. So that's what we expected to hear on the inside as well. That's not what we heard. The 2 primary things that we heard is that people wanted when they were giving birth, when they were in childbirth, they wanted a support person. That's the first thing. And then the second thing is that they wanted to be able to breastfeed their child, or at least to give milk to their infants. So we took up both of those issues, and I'm going to start with the second one because that's actually the law that we were able to get passed first. The problem is lack of access to breastfeeding and lactation when you're incarcerated. And here's a quote from someone. I'm going to be giving several quotes just to sort of kind of fill out the problems that we saw. None of these are from CRDF. Largely, they're from other jails, Orange County jails primarily, since that's where I work. So I just wanted to let you know this is not like a passive aggressive way to call y'all out. These are from other jails, but I just want to flesh out exactly what types of problems we're seeing in jails in California. So this is from someone named Lola. When I was incarcerated, I felt like a bad mother. I wasn't able to be there for my baby. I wish I could at least breastfeed my baby so I could contribute. So that led to the passage of AB 2507. This law was passed in 2018, but it was a 2-year implementation period. So it was passed in 2018 and it was in effect January 1st, 2020, and then COVID happened. And so we were hoping to spend a lot of last year, going into jails and prisons and talking to folks about how to implement this law. And then obviously all of that got taken away with our inability to visit jails and prisons. And so we are kind of hoping to start that again anew this year when rates are looking a little bit better and jails are a little bit more open. But the law, AB 2507, requires 4 things. And these 4 things can fit on one slide because the law is actually very simple in its language and in what it requires. And the reason that happened is because we wanted to provide something that was really straightforward for jails. And then we said that we could kind of get into the complexity in the implementation, which is what we're here to do now. But the law, as far as the minimum requirements, are very simple. So first, it requires that all jails create procedures for providing medically appropriate support and care related to the cessation of lactation or weaning. Second, create procedures providing for breast milk expression, disposal, and same-day storage for later retrieval and delivery to an infant or toddler by an approved person. So this is the pump and pickup program that we're all here to talk about today. It's that second requirement. Really simple, just one line, and it's about expression, disposal, storage, and delivery. That's all the law requires. The third thing is create procedures for conditioning a person's participation in the program upon the lactating person undergoing drug screening. I'm going to get more into this later, but I want to highlight right now that it does not require that a positive screen essentially prevent someone from entering into this program. And that's on purpose because that we know that this is really a decision between the person and the medical practitioner. If you all in your expertise believe that the person can still safely deliver breast milk, then a positive drug screen should not prohibit a person from being able to pump breast milk and have it delivered to their infant. And so that's just what I want to, it requires a drug screen, but it does not say that a negative or positive, mandates a particular result or a particular consequence. And the fourth thing that it requires is the infant and toddler breast milk feeding policy for lactating people shall be posted in all locations in the jail where medical care is provided, and the provisions of the policy shall be communicated to all staff persons who interact with or oversee pregnant or lactating persons. It seems like this has been done since you all are here and aware of the policy. And then the first part of that last piece is just, the typical posting that is required with most laws that are applicable to people who are incarcerated so that they're aware of their rights. So these 4 provisions, the law is incredibly short. If you look at, I don't know how familiar you all are with looking at the text of laws, but typically they are long, they're complicated, they're referring to different sections. This law, if you Google AB 2507, it's just these 4 provisions. It's very short. And the reason is because we know that each jail kind of has its own, its own mechanics, its own way that it operates. And so we wanted to kind of leave some flexibility for jails to do what's best for the particular people that are, that are housed there. So, which is where we get into a model policy and a toolkit that we're hoping that jails will be able to implement so they can, and so this is sort of like the best practices that we've found by doing a review of jails here in California and elsewhere that have a pump and pickup program. The model policy and toolkit is, it is an actual document that we're kind of in the process of finishing now. The current stage is that it has been drafted in English and we are getting it translated to Spanish, and then it will be ready to go. So it will soon be on the website of ACLU of Southern California and the California Breastfeeding Coalition, likely within the next month. And when it's ready, I can circulate it to this group or to anyone who's interested in having it. But for the purpose of this presentation, I'm just going to go through the, what the model policy and toolkit has in it. So you're all aware of what to expect when it's ready. So the first part of model policy is notification of the program. The program does no good if people don't know that it exists. So the people who we believe should be kind of in charge of notifying incarcerated people of their rights are medical staff, so you all, because you are who they're coming to when they need to learn how to breastfeed and take care of their baby. And two, at intake. And the reason is because part of the law requires that there is, an intake screening procedure with a drug screen in it. And so we think that when you're doing that intake, that's a great time to just inform people that this program exists and that they have the option of opting into the program if they want. So those are who we think should be, should be telling people, notifying people about the program. What they should be notifying people about is existence of the program, the benefits of breastfeeding, the risk of lactation with HIV, drug use, and some prescribed medication. And clearly that is very dependent on the person and their particular situation. And the benefits of receiving medication-assisted treatment for opioid use. After my section of the presentation, I'm just going to quickly go through some of the pieces of the model policy and toolkit that we have just to show you what it looks like. So one of the things I'm going to go through is the benefits of breastfeeding document. My initial plan was to kind of go in and out of this presentation and do it while I was kind of pull it up while I was doing this presentation, but I'm nervous about kind of losing my screen share. So I'm going to do it all at the end now. Okay, so after notification, the next thing that needs to happen is identifying lactating persons. And there are several ways that we recommend that a person is identified as someone who is lactating and someone who wants to be part of this program. The first is at the intake screening. And I'm going to pull up at the end kind of what an intake screen could look like. The second is a request to jail staff. Third is discharge after childbirth. Fourth is sick call slip. And fifth is a clinic visit. As you can see, this is a pretty broad list, and this is kind of the list that we've come up with to allow lactating people who are incarcerated to inform medical staff, custody staff, that they would like to be in this program. We think that it shouldn't just be one way. It shouldn't just be at the intake screening. They should have kind of multiple opportunities to opt into this program if they would like. The next part of implementing this program is buying the equipment. So we have an equipment checklist that I'll show you at the end of this that includes breast pumps, breast milk expression storage accessory, or breast milk expression accessories, breast milk storage containers, and breast milk sterilization products. Someone in Hannah's presentation asked the very good question of whether an electric hospital grade pump is required under the law. The answer is no. As you could see, that the law is actually very bare minimum. It just says that you need the necessary equipment in order for expression, storage, and delivery. And we're kind of leaving it up to the jails to decide what that necessary equipment is, though we very strongly recommend that that all people are provided with an electric pump. And you'll see that on the equipment checklist. So the next part of implementation is setting up the location, setting up the lactation room. So we recommend that there is a comfortable chair, electricity for the electric pump to be plugged in, a flat surface to put the pump and to put the accessories and the equipment, a storage space for individual pumps so that everyone has their own pump and they can store it in a cubby or a locker or something like that, a sink for cleaning, the cleaning supplies, and the breast milk expression accessories. This is essentially the same list that we provide for any type of breast pumping location that is set up. So whether that is for employees, whether that's for in court, whether that's in airports, this is sort of the list that's the minimum requirement for people to be able to pump breast milk comfortably and effectively. And then the additions for the jail setting are kind of the last pieces of that, which are the storage space and the cleaning supplies, because in incarceration you also have to provide folks with that since they can't get it themselves. The actual pumping, we recommend that you escort the lactating person to the room. We also recommend that they have freedom of movement when they're in that room, that they're able to get up, sit down, stand up, walk around, sort of do what they need to be most comfortable while they're pumping. And then we also very strongly recommend privacy. This is the question that we get most often with AB 2507, is whether, we hear a lot from custody staff that it's not safe, or they're not able to just leave the lactating person in the room by themselves. We really recommend as much privacy as possible. This is obviously a very vulnerable thing that they're doing. Their breasts are out. It is stressful in a number of different ways, and we're really trying to decrease the amount of stress in this situation. And so, kind of at first, the first recommendation would be to just allow them to be in there by themselves to pump. And if that's not possible, then we really recommend that it's medical staff that's in there to help them through that process rather than custody staff. Next is the time, which Hannah went over, that it's really important for folks to have a schedule. And that schedule is usually every 3 to 4 hours and usually for 20 to 30 minutes, though it does differ person to person. And so it's really important to kind of, for you all as medical staff, to create that individual schedule with that person and really facilitate them being able to stick to that schedule so that they don't have other obligations at that time. For storage, we recommend that there are breast milk storage containers and a freezer and refrigerator if possible, but at the very least a freezer so that the milk can stay in there for longer if it takes a while for the person on the outside to come pick it up. So this is really the kind of the complicated part of a pump and pickup policy, is really the picking up. So this is a several step process. The first is the incarcerated person will submit an approved person form. That form, which I will show you at the end of this presentation, or a sample of the form, will say who is picking up the breast milk, and then their relationship to the incarcerated person, and if possible, what the schedule of pickup is going to be. The law allows for multiple people to be approved people, and this is really what we recommend as well, because it might not be possible for just one person to pick up the breast milk every time. And so, if multiple people, if 3 people, 5 people, 10 people need to kind of work together to be able to pick up and deliver breast milk to that particular baby, we really, recommend that the jail allow for that. The second is to arrange coordination of the pickup. The incarcerated person might be able to do this with the approved person from the outside, but this is another thing that we really recommend that the jail help with, because obviously it's not easy for folks to communicate when they're incarcerated. And so just, to the degree possible, to help arrange the coordination of the pickup of breast milk. Then the other really important piece, which Hannah also touched on, is logging the date and time of the pickup. And so Hannah talked about how important it is to log the storage, how much, how many bags are being stored, what the date is, and who the person is. The other piece of this on the other end that's really important to log is when the bags are picked up and how many are picked up and by whom. And I'll show you kind of at the end of this a sample log for date and time of pickup. Then the next step is to provide the approved person with the breast milk and a cooler, if possible, for transportation. And if not a cooler, then at least ice or another way to keep the breast milk cold. And then finally, provide the approved person with instructions on transportation. That is another thing that we have as part of the toolkit, is just a document that you can give the approved person. It's really important to not assume that the person who's picking up the breast milk has had the same type of training on, how cold to keep breast milk and how to transport breast milk. And so the more information that we can provide the person on the outside, the better for everyone involved, because that really, that just facilitates the baby receiving the milk that they need. And then, of course, there's going to be some times when people don't pick up the breast milk. And so failure to pick up, recommended is that the breast milk is discarded after 6 months if it's frozen and 6 days if it's refrigerated. And, folks in jail are kind of coming in and out. And so we also recommend that when a person is released, if any of their breast milk is at the time frozen or refrigerated, that they're able to take the breast milk with them upon release. So the things that are particularly important for you all to do to support people who are lactating and pumping in incarceration is, first, is to wait until custody staff leaves the room. This is the piece of trying to ensure as much privacy as possible. To discuss the schedule and any other healthcare needs related to breastfeeding and pumping, but obviously also in general. To instruct to wash hands, just instruct on hygiene in general and not assume that, folks know all of the ins and outs of how to keep their equipment and themselves clean. Teach on how to use the breast pump. Instruct on breast milk storage containers and how to sort of log all of that information. Direct folks on cleaning and sterilizing the breast milk equipment, and also assist with any education and medical needs. So this is the larger part of just educating people on breastfeeding, on the benefits of breastfeeding, on any risks that you see for this particular person. So that's kind of, this is the list of where you all come in and where you can help in a way that other people can't. So that's the piece that I wanted to go over, specifically related to AB 2507, the pump and pickup program. But there's also one other piece that I wanted to review while we have you here, which is a new law, AB 732. Some of you may have heard of it. It was just passed last year, and it was implemented on January 1st of this year. And we know that many jails are kind of still in the process of implementing this law because it did a lot. It was a really comprehensive law on reproductive health care in jails and prisons in California. And so I kind of just wanted to go over some of the very basics of this law so you all can kind of help look out to see if this is also being implemented and facilitate that along the way. So the law does a number of things, and I also got to help draft and work on getting this bill passed as well. So this one's very close to my heart as well. So one of the problems it sought to address and did address is lack of access to menstrual products. So here are 2 quotes from folks that we talked to who didn't have access to menstrual products. Beatrice said, "They gave me 2 pads for my entire cycle, so I bled through all my clothes." And Amanda said, "They gave me 3 pads a day. 3 pads a day is not enough. That's why you have girls stuffing toilet paper in their underwear." This is something that we see that's very, very common, is that folks just aren't receiving sufficient pads and tampons, and that people were having to pay for tampons. So AB 732 requires sufficient pads and tampons at no cost. One thing it doesn't do is specify the number of pads and tampons. And so this is really where you all come into play, just to make sure that people are, being provided with enough pads and tampons that's, could be unique to the person. Some people might need more, that's sufficient to get them through their entire cycle. The other problem that we saw was lack of access to abortion. Kate told us, "I told the guard I wanted an abortion and he laughed at me." Another thing that AB 732 does is provide access to birth control, contraceptive counseling, and no conditions or restrictions on obtaining an abortion, such as gestational limits, delaying access to the procedure, or requiring court-ordered transport. On the first one, access to birth control, what it requires is that if someone is on a particular form of birth control before entering the jail is required to continue them on that exact form of birth control if they want to be. And then the second thing that it requires is 60 days prior to release, the jail can put them on any form of birth control that they want. The exception to this is sterilization procedures are not allowed. The other problem that we saw is inadequate pregnancy care. So Amy said, I was pregnant at the time of my arrest and I had irregular bleeding and asked for medical attention, but no one came until the next time. The doctor told me I miscarried. So we saw a variety of problems regarding inadequate pregnancy care, including people weren't being given prenatal visits and prenatal vitamins. They weren't being given extra food. They were being assigned an upper bunk rather than a lower bunk, and they were being shackled in ways that were dangerous to the pregnancy, such as behind their back. So AB 732 addressed each of those problems point by point. So now a pregnancy test must be offered within 72 hours of arrival. It must be offered, but it can't be forced upon a person. You have to, you say there's a pregnancy test that you can take if you would like it. And if they don't want it, then they are not required to take it. And if the person tests positive for pregnancy, that triggers a number of other requirements. So it triggers pregnancy counseling to options counseling so that they know their options in pregnancy, a care plan with mandated schedules that reflect what ACOG recommends. So, for the first trimester, every few weeks, second trimester, slightly shorter, third trimester, every week, that schedule is the schedule that all the jails in California should be following. It also requires diagnostic testing and scheduled visits, and information about pregnancy testing and pregnancy care rights must be posted in at least one conspicuous place. So same as the pump and pickup program, information about pregnancy also needs to be publicly posted. And as far as the prenatal care requirements, it requires care, evaluation, and treatment for infectious diseases. This piece actually became surprisingly important last year because of COVID-19. And so this is included that all people in jails and prisons should be tested, treated for COVID-19 symptoms. But even if that wasn't true, pregnant people would have to be because it's mandated by AB 732. The other thing that's mandated is a special prenatal diet and prenatal vitamins, methadone treatment if needed, a lower bunk assignment. So pregnant people should not be given an assignment that requires them to climb up a ladder. It's AB 732 also prohibited tasering and pepper spraying of pregnant people and shackling behind the back or at the waist. The only proper way to handcuff someone who is pregnant in California is in front of their body, if handcuffs have to be given. The other problem, when we did our reproductive healthcare behind bars report years and years ago, the problem that we kept hearing is that people were giving birth alone. And so this is from Nikisha. The only people in the hospital room were the doctor, nurse, and the correctional officer. He was staring at me the whole time like I was going to get up from the bed and escape while I was giving birth. I didn't have my husband. My husband missed our daughter's birth. So AB 732 requires that folks give birth in a hospital, that they're not shackled through that entire process, including transportation, labor, childbirth, and recovery, and that they be provided with one support person during labor, childbirth, and recovery. So someone's partner, someone's mom, someone's best friend is able to be in the room with them while they're giving birth. And then the last thing that AB 732 required is postpartum care. So postpartum exams should be scheduled as needed for 12 weeks after birth. So here's some information on what we have at ACLU of California on Know Your Rights issues with reproductive health in jails. So our AB 2507 toolkit is coming very soon, likely in the next month, and that's what I'll circulate. We have a Know Your Rights document on reproductive health care in jails. That's the link. And that's being updated very soon, as is our report on reproductive health care in jails. Those two are both being updated because several new laws have passed since 2016. And so we're just updating them to reflect the new laws. And that all should be done within the next month as well. And that's my email address if anyone would like to contact me. And then the last thing I'd like to do, if I can figure out how, is go over some of the pieces of the toolkit. All right, let me see. Okay, can you all see that Word document?
Yes, we've got it.
Verbal. Okay, perfect. All right, so this is a Word document called Benefits of Breastfeeding. And this is a document that we recommend that you give to the lactating person, and also counsel them on these issues, but give it to them just so that they have it and that they can refer to it if needed while they're making their decision on whether they want to participate in this pump and pickup program. So the first piece is the scientific evidence that supports breastfeeding, most of which, if not all, Hannah went over. The American Academy of Pediatrics recommendation on breastfeeding. Quality of human breast milk. Here are the risks of not breastfeeding, both for the infant and toddler and for the mother. Economic and environmental benefits of breastfeeding. And then here's a very short section on risks. And the reason that we've included that here is just so the lactating person is aware that there might be some risk to that particular person, but really it's medical staff that really need to work with them to determine whether or not it's safe. Oops. All right, so I'm going to pull up one more document. Okay, so this one is the intake for the infant and toddler breastfeeding program. This is an intake that can be adapted to the particular needs of CRDF, but here's just a sample of what it could look like. So you might remember that I said, 30 minutes ago that AB 2507 requires a drug screen. This is where we recommend you put the drug screen. We really want to emphasize that the law does not require a biologic test. It does not require a blood test. It does not require a specific type of test to do the drug screening. So we recommend that the drug screening is done as part of the intake form. So here's what the intake form looks like. It's very simple. It just says, are you pregnant, postpartum, and or lactating? If you're pregnant, when's your due date or delivery date? If you're postpartum or lactating, when did you give birth? This is all just to give you as medical staff information about when exactly the person needs information and might need to be trained on this particular program. The second is, do you wish to participate in the program? Third, do you have experience with breastfeeding and or pumping breast milk? Obviously, people are coming to you with varying levels of experience. Someone might have breastfed their previous 3 children and know exactly how to do it, and they just need the equipment. And someone might be brand new, have never thought about it before, and needs all of the education before they can even start to think about whether they want to participate in the program. And so this is the section where you can kind of gauge that level of familiarity and interest. And then the fourth is tell us your current goals for breastfeeding. We let this be open-ended so that folks can kind of put in what their hopes and goals are for breastfeeding. And then here is the drug screening requirement. And it says at the top, this is only for the purpose of a legally mandated drug screening requirement. Your responses to the question below do not necessarily impact your eligibility to participate in the breast milk feeding program. Your medical provider will discuss with you whether it's safe to breastfeed with your particular history. So the next question is, do you have a history of drug use or addiction? Number 6, are you currently under the influence of or have you consumed in the last 48 hours any illegal drugs? And if so, list the drugs. I really want to highlight that this should not be used, this should not be provided to anyone other than medical staff. This should not be used to, extend someone's sentences, file further charges, any of that. It's very important that it's not. Otherwise, you all are not allowed to give, or you're not able to give adequate medical care. This also should not be used to prevent someone from participating in this breast milk feeding program. We're really just including it here because it's legally required, and so that you all as medical staff have all the information you need in order to be able to advise someone on whether it's safe for that particular person to breastfeed. All right. Okay. So here's the next form. It's an equipment checklist. And I kind of went over briefly the sections of the equipment checklist before, but here's just some more, here's what it looks like in the toolkit. So the first is breast milk expression pumps and accessories. Here is the list of pumps and accessories that we recommend each jail provide to the lactating person. And as you can see here, electric pumps are included, and we included, the specific number of the pump so that you can easily find it. Here, breast milk storage containers. Here's what we recommend in order to facilitate the storage of breast milk. And then finally, we have the sterilization products and equipment. This is what we recommend each jail provide the lactating person so that they can clean and sterilize their equipment. I have 2 more documents.
Aditi, there's a question in the chat about
yeah.
whether or not the PowerPoint presentation will be available post-meeting.
Absolutely. Yes, we can circulate this after this meeting.
Okay, great. So I will collect all of that. We'll put it together for you in one document. Anything that we have that we can send you, we'll be sending to you after we're through.
Perfect. Thank you, Hannah. Sorry, I think I chose. Oh. Okay, so here is the tracking log. This is really what we get asked about most often because I think this is the part that's really tricky to do. So the tracking log here, our sample log, has the incarcerated person's name and their booking number, 2 names of an approved person to pick up from the outside, and then the 2 kind of important sections of the tracking log are the storage and then the pickup. So the first part is the storage. This is where the breast milk was collected for the when it was collected for the freezer. So this is the date and time, number of bags collected, the initials of the incarcerated person, and then the last 4 digits of the employee ID who helped with the collection, storage, and then writing the initials of the initials and booking number of the incarcerated person directly onto the storage container. So that's the first part of the pump, and then the second part is the pickup, which is the approved person from the outside coming to pick up the milk. Here is the date and time of pickup, the last 4 digits of the employee who gave them the breast milk, whether a cooler was provided for transportation, number of bags that they picked up, and then the initials of the person who picked it up. So this is the part that this is why this particular policy is pretty difficult to implement because it requires so many moving parts. And we really recommend that all of the moving parts are documented in one document, in one tracking form, so that we could see it all the way through. Essentially, you're tracking the storage container, the storage of breast milk all the way through. And then I have one last document to show you. There we are. So this is the approved person form. So this is the form that when the incarcerated person decides that they want to be in the program, and again, there's a number of ways they can decide that. They can decide that at intake, like the orientation for when they get into the jail. They can decide that at any medical visit that they're in with you. They can just decide that themselves and inform jail staff. They can put it on a sick call slip. Really, any way that they have to communicate with the jail staff should be available to them to opt into this program. And when they decide they want to be part of the program, in addition to the intake screening and the benefits of breast milk and all of the documents that they're provided, they should be provided with a designation of approved person. So this is how they tell you who from the outside is going to be picking up the breast milk. So this is their name, booking number, date of birth, name of the infant or toddler, date of birth of the infant or toddler, and then the names of the people, person or people who will be picking up the breast milk. Again, the law does not require or does not limit to only one or two people. The law just says, there will be people from the outside who can pick up breast milk. We really recommend that the jail allow as many people as the person needs. You all are aware that CRDF is kind of in a remote location, and people might be coming from all over Southern California to pick up this breast milk. And so in order to make it as easy as possible on the people on the outside to pick up the breast milk, we really recommend that people be allowed to designate several different people. And that the approved person will be required to provide government issue ID so that we know that they are who they say they are and they're getting the correct breast milk from the person. And then an understanding that the jail will discard the breast milk if it's not picked up within 6 months. So that is okay. So those are a few of the pieces of the toolkit that I wanted to show you all. There are several more. A lot of the pieces, a lot of the things that I went over today are contained within the toolkit itself. So when that is ready, and again, hopefully it's going to be within the next month, and it will be available both in English and Spanish, because we know that a lot of the folks that you work with are monolingual Spanish speakers. And so documents like the benefits of breastfeeding, documents like that will be available in Spanish so that you can provide it directly to them. And the intake form, any kind of public facing document will be available in Spanish. So that should be available within the next month or so. And, similar to what Hannah said, we are very, very available as a resource to help at any step of this. We're all kind of doing this for the first time. California is the first state to have such a comprehensive program. In fact, we get calls from other states and jurisdictions all the time saying, we heard you have this really great law. Can you help us either pass a similar law or talk us through what implementation of that law looks like, or what the toolkit or model policy looks like. And so this is something we're as usual, we are at the forefront of doing this type of work in jail specifically. Prisons kind of operate differently, but in jail specifically, we're really at the forefront. So we're all kind of working through this together, and we are very here to help troubleshoot if there's any way that we can help. And I am happy to take any questions that you all have now, but also the presentation will be available, and it contains all of our contact information. So, please feel free to reach out afterwards as well. So yeah, so does anyone have any questions? All right, I'm seeing no, so I'm going to hand it back to Hannah, and just really thank you all for being here. I know it is early, and we all have a lot to do, and it's just really this is such a dream to get to present to people who are on the ground and actually doing this work. So thank you.
Thank you so much, Aditi. We will be taking a break actually now until 11 o'clock, where Dr. Saida will be back with us and able to go through some of the more practical aspects of this. So that's going to be largely conversational. We hope that you will actually, ask questions and engage in conversation with us around how this work starts practically at your facility. So we will see you at 11 a.m. That's about 10 minutes from now. Thanks, everyone. Hi, everyone. It's 11 o'clock, so we'll go ahead and get started back with Dr. Pepra.
Hi there. Here we go. Okay, there we go. So I am really eager to have folks turn on their cameras and or open up mics and ask questions or just have conversation about like the practicalizing of the things that have been discussed today. I empathize with, you know, the actual people who do the work on the inside when a policy or a system has come from outside of the correctional context that has lots of expectations for what it should look like and how hard it is to actually achieve that goal and how much pushback those of you who may be interested in, you know, seeing changes or opportunities for those that are in your care, how many people inside may have difficulty understanding why this matters, wanting to participate, or just the barriers of the moving parts, because, you know, correctional systems are people moving systems. They're not mechanical. They're not systemic in the outside ways where you put a policy in place and everybody's just going to follow along. You have, you know, sometimes individuals or systems or aspects that can make it feel impossible or really challenging. So I'm happy to help you think through anything that might have come up. And then you have to remind me again, if you can, even if you haven't thought of questions, can you tell me your positions again, those of you that are in the facility?
Nurse practitioner Harris. I'm in CRDF. I'm a nurse practitioner.
Okay. And you're a nurse practitioner, just general for any and everyone who needs services, or do you have a specific population?
I manage the OB line and do routine GYN appointments, specializing.
Okay. And who else do we have in here? Do we have any like officers, correctional guards? Do we have anyone from mental health? Hannah, do you remember the positions? Because I don't know if people had maybe stepped away. What other types of
Absolutely.
folks?
We have some NPs, we have some RNs on the line, some case managers. We've got some medical social workers, and I believe we have some officers and custody assistants.
Okay. Who is on the line that's the most likely to have to physically engage with the pumps and sort of like the practicals of that?
Most likely everyone. I'm not so sure about case managers, but definitely our RNs, our NPs. You know, we have, you know, my understanding from talking with Nurse Betty was that a lot of folks are actually pumping in their cells right now.
Okay. So how is it going right now with people pumping in their cells? What does that look like? There's designated storage, and I'm sorry I had to pop off in the middle, so you guys might have addressed that. Is there storage being had right now, and what's the purpose of the pumping? Just to express to get it out, or is there getting it to the baby as well?
Here at CRDF, the patients pump at their housing location, and then on nurse or pill call, they will give the the bag of milk to the nurse, the RN that's passing meds on rounds. And
Yep.
then the milk is stored here in the main clinic here at CRDF in a basket with their name on it.
To what purpose is it stored? Is it going to get to the baby?
Yes, so it's frozen, and then we have a pickup program. So the nurse, you know, when they come back from the hospital, they have a contact person, and they give their information, and the family comes. They're supposed to come once a week. But I do have some patients that do pump and dump, just because they don't have a contact person to pick up the milk, or the baby's in foster care until they are released.
Right.
So it's both just for pickup to from the cell to the nurse, and the nurse will put in the freezer for storage for a week at a time, and we keep that until a family member or their contact person picks it up. And then there are some patients, like I said, who just pump and dump just to keep the milk production active.
Because they know they're going to go home within a month or so, and so they want to have breast milk for the baby when they get home.
Exactly.
Yeah. Okay. Is there and does that go pretty smoothly with the pill line nurses? I mean, I know in our facilities, you know, pill line could go a couple hours before they get back to, you know, the place where they could have stored anything or even return medications. Does that go pretty smoothly?
Well, I make a correction. So there's like a nurse clinic, I guess you should say. So on each shift, there's a nurse clinic.
Comes the pill line.
Yeah. So
Got
it's
it.
not the pill line. It's like a nurse clinic that they can give it to. And on every shift, there's a nurse clinic that they can report to and give the milk to a nurse.
Okay, that makes sense. Okay, yeah, I got it. That makes sense. Bringing back all the memories. Okay, so we have a couple facilities on the line, and we have one facility that is already doing, you know, some lactation access, and then there's other facilities, Hannah, that are on the line too.
I believe we only have one facility on the line.
Oh, okay.
Let's see. We have somebody in the chat saying, hello, I'm having trouble with unmuting. I'm the program manager of the release planning program at CRDF, and several of the participants on this call are medical caseworkers and social workers.
Okay. And just for clarification, is everybody from the last facility, from the same facility? I think that's maybe a question to the last speaker.
The answer is yes.
Perfect. Okay, got it. What do you foresee any concerns at all with implementing any of the additional things? Does it feel like, well, we already have a system, and so there's not much of an adjustment to make? How is the information feeling like to everybody?
This is Nurse Practitioner Harris again at CRDF. So we have the program for the pickup, and they can pump and dump. So that's, as far as I know, is going okay. But the one thing, the new law or requirement for the person to have a support, the patient to have a support person at bedside, we are still working on that with custody. So that's been a little bit of a challenge to implement, but we are actively working on that now.
And Hannah, that support person is like a doula for birth? Is that at bedside for birth?
It could be either family or if they don't have family members, we're working on making sure that they have like a doula or someone there other than custody and just hospital staff.
Okay, but this is bedside for childbirth, right, Hannah?
Oh, for me, is that question is for me? Then yes,
Yes.
This is bedside for childbirth, new law that came just beginning of this year. Mm-hmm.
Okay.
Right.
What are some of the challenges that you could foresee with that, like the logistics of that?
So this is RNPRC and at CRDF. It's custody being on board with, because we're a 24-hour facility, right? So they could actually go with childbirth at any time. So if it's not induced or scheduled to have the delivery at LCMC, having a support person at Francis or King, that logistic will be an issue, right? Because we don't have a contract with them on how they deliver. And for the planned deliveries at LCMC, if they don't have family to be at bedside, from my understanding, the custody side of that, I don't. Dr. Nattel and I are working on it. I don't know what the barrier is, but we haven't established a plan on how or who we can get to be on call, so that that they can go with the patient or whatever. So that's just ongoing at this point.
Okay. So there are a number of facilities around the nation that, not a lot, but there are a few that have, not on site, but they have doula and lactation programs. And I've on committees with several of their those facilities on the side of those that are doing the support to them. And what a lot of them have found to be successful is that they partner with an outside, community doula organization who has on schedule and on call process. They typically do extensive, sort of like security and orienting to correctional services training with the perinatal support people or the doulas or the lactation help folks or whoever is, because in some of these facilities they have outside lactation consults that come in, during visitation time, let's say, and that they're available to the lactating individuals. And then they have community doulas that are assigned, to the facility and familiar with the hospital and get to connect with the patient or the client in advance of birthing so they can prepare the way a typical doula would. And so in some of the facilities, they're invited to come into the facility and they do that live, and they do, like childbirth education classes with them. In some of the facilities, they're not able to come in because of, various security and logistical reasons. And so then they have phone call conversations that are managed. I know at one facility, with during case management sessions, that they allow them to have time, almost like you would do like a legal call to a lawyer, and you give them that space in the room to have those calls. And so then they have, virtual training sessions with the doulas. And then the doulas are on call with an outside organization. So there's a contact at the facility. Typically, it's whoever is the on-call medical person or social work, depending on who does more of that. So in our facilities, psychology, actually, if we had done a program like that, would have been the best, because we're going to be in communication with health services very actively. We had an independent psychology department, so it wasn't within health services, but obviously we work in tandem. And then we had on-call schedules just like health services did. And so if the psychologist was on call, and obviously we would have people will go into labor. And so we, that whoever that person would be, so you just sort of give you ideas about who you could think of, would communicate with the community doula program or the organization that you're partnering with to provide the bedside services. And they would send out the doula, and they'd be responsible for making sure that person gets there. And then because it was already set up and everybody has a contract and everybody is aware, it becomes as seamless as possible. I don't think it would be best practice to have officers as that person by bedside, unless you had someone in the department, and I would say maybe like from psychology services or social work, like someone who has skills in people support, soft, gentle, not necessarily only focused on, sort of correctional and security. And then that person be trained as a labor support person. If it had to be something in-house, I've triaged ideas with folks about this before, but I don't know any organizations of any correctional systems that have used in-house people. It typically has been outside folks, but there's been a lot of conversation about that, and I'm sure that that'll happen eventually, that someone would be trained in-house to do it. But obviously you'd have to have multiple people because birth is spontaneous and it's 24 hours. And while doulas typically do work at the whole course of labor, and so if a client, a laboring person went into labor and it's 18 hours or 12 hours, typically a doula would stay the entire time. You couldn't do that with your staff. And so it doesn't really work to have staff because they change out, and changing out in the middle of labor for any of us that have labored is not ideal to have like this variability. Oh my goodness, in an hour, if I don't have this baby, you're leaving me. And I've been, you know, like you've been helping me cope all this time. So it really has to be designated and dedicated people that also don't have any pull for other systems needs. So that person needs to be able to be focused only on the client and not on safety and security, for instance. There should be someone else doing that. And typically there is someone else designated to do that because they're doing that. So those are some of the things that I've seen that have been helpful and that have worked. And I would probably recommend that, thinking about partnering with outside folks and then strategizing systems together. And if you would need to, I think some of the other successful programs, they definitely want people to know about what they've done because they know it's possible and they know that it took a lot for them to figure out all those policies and procedures. And so there's a couple documentaries and there's some information out there about those. And if you're not familiar with them, I'm happy to give that to Hannah so that she can forward that to you guys and you can, you know, kind of see what they put out. And if you wanted to contact them, I imagine they'd be receptive to that.
All right, thank you.
What other thoughts, ideas? I'm curious how like mental health and psychology services, if they get involved at all in like perinatal mood disorder stuff or any emotional support. We definitely know that can have an impact on lactation. And so curious if they have been a part of these kinds of conversations or if they do any direct things with the pregnant and postpartum folks. I'm sorry, last speaker, if you keep being the only one. Definitely other folks, please feel free to add and comment. And I think, sorry if I pronounced your name wrong, Ariate. If you wanted to type in, you could. I'm looking at the chat too. I think you said you couldn't unmute. No other questions, thoughts? Okay. All right, well, I'll hand it back to you, Hannah, and I'll stay on if people think of something.
I guess I'm wondering at this point if anyone would want to share with us kind of what it looks like now, what issues you might be having with supporting people with lactation, whether those are individual issues, whether those are more systemic issues, and whether, you know, how you feel about implementing a program like this. What do you think are the things that are worthwhile, and what do you think are the things that are non-worthwhile, and why? So someone in the chat is saying, I'm a medical caseworker. Why can't I see all this? There it is. I've begun to give targeted information with being pregnant. If it's good information to know, oh, it is good information to know what I can include when I follow up with clients. Absolutely. So Leticia, you're doing, you know, prenatal education more or less as a medical caseworker?
And I'm wondering if we can, because I can't see Leticia on the list of participants, but I wonder if, Leticia, are you having a hard time unmuting? I'm wondering if we could help them, but I can't see anyone else. Okay.
So she's focused on release planning and how they can better address the needs of the client.
I would imagine that a lot of times there may be a question about, and I know I saw this with our women, not wanting to create, like sometimes there's a lot of variability, like they don't know that they're going, how quickly their case is going to resolve, when they're going to get out, whether or not they're going to be able to reunify, and how quickly. And is it pointless then to pump? Is it pointless to, you know, even do the skin to skin at the hospital? Like, I'm just going to go, I want to, you know, be as detached as possible because maybe it's not good for the baby. And I think, you know, just really encouraging the concept that, you know, the infant's first experiences in the world really do frame a foundation of the way that they experience this new world they've come into. And so being able to be, you know, in the loving and warm arms of the person whose body, you know, has been holding them all these years, being able to, oh wait, I'm just gonna look what you said. Okay. You know, being able to have access to something that's going to boost their immune system, and the benefits that it's not 1 week, 2 weeks, 3 weeks, any amount of breast milk is so significant to the physical body, especially since they'll be separated from mother, especially since, you know, there may be some variability with who cares for them when they're on the outside. And so, you know, as hard as it is, I think it is important to sort of frame that it's a way to create this beginning experience for the infant, even if it feels counterintuitive to allow for closeness and then separation. A lot of people don't realize that infants are very primed to be able to go to different people and to be able to be cared for, you know, by the village in a lot of ways. And so, you know, where you have that separation anxiety with a 9-month-old, you know, where they're screaming, you know, when you leave them with the babysitter or with even, you know, grandma, they're not used to that person. You know, an infant, as long as they're warm and clothed and fed and healthy, they feel they can find safety in the arms of people who care for them. And so it's not harmful for the baby. It's helpful for the baby to have all of the engagement with all the people possible, you know, that are safe and available. And so just, you know, letting them know that that's okay. Somebody asked, do you find access to doulas more common in rural areas? Absolutely not, actually. Doulas are a lot more in urban areas and in suburban areas, more particularly than in rural. But there have been rural regions that have been successful at creating doula access programs, even with correctional, because of the fact that it's a smaller environment and it's been easier to communicate and to create like system, you know, very succinct systems. There's a single hospital that everybody's going to. And so there's a single correctional facilities and there's a single set of doulas. But no, not necessarily in rural areas. It's definitely, but for Southern California and for California in general, we have a really vibrant doula population. I mean, I feel like we have the most doulas, you know, in the nation in one state. And I travel a lot, and there are a lot of places with doulas, but California is really, really, really active. And previously it would have been mostly for, you know, affluent, you know, families that want to hire a doula. But now with all of the opportunity for funding community doulas, we have a really vibrant community doula programs that are going on right now. I have a program called Frontline Doulas, and we have been able to you know, bring community doulas together to do various projects. We did one for HealthNet, the insurance company, to provide doulas for Los Angeles County back in 2019 and 2020. We did a COVID-19 initiative where we were able to bring funding for doulas, Black doulas in particular, all over California to serve clients wherever they were. And there were a number of doulas that were out there. We gave scholarships to 50 doulas during COVID to be able to provide births. And so there's opportunities for partnership with doulas in California for sure. Our release planners will provide the informational handout and will closely work with nursing when medical questions arise. If we have questions on handouts or providing information, who can we contact? I think that's for you, Hannah.
Yeah, so I would probably be the best contact because I can help you put you into contact with everyone else. So I will put my email in the chat, and you can absolutely please reach out to me. I think Aditi said it and really said it beautifully, is that, you know, everyone on the line today, we're so excited just to have the opportunity to begin the conversation. We know that it's really not going to all resolve or be implemented, you know, quickly and overnight. What we know is that if we can create some investment in those who have access to those that are incarcerated, then we're going to be able to make a difference alongside you in the work that you're already doing. So we do want to assist you in that. We want to, as Saida said, make it easy for you to navigate some of the practical obstacles that are going to come your way just from working in a system that has to have, you know, meet certain criteria. So I will put my email in the chat right now, and you're more than welcome to reach out to me individually. And we will be providing for you as well. I know Breastfeed LA has put together 3 documents. We currently only have them in English, but we will look to get them translated into Spanish and then a few other languages as well. One is going to be on, it's actually a document that we created in order to give out to pregnant folks who are trying to talk with their families about supporting their lactation journey while they're incarcerated. So this is really for the caregiver of the infant. Because that's something, as we said, you know, we can do the education for you all. You can educate the person who's incarcerated, but who's educating the caregiver of the child? And so we really advocate for pre-planning in regards to, you know, when we know that this separation is going to happen, what conversations are we having around how to store milk, how to feed baby, you know, picking up all of those things that Aditi talked about. We also are going to give you a one-sheeter basically on how to include it in a custody, you know, in your custody arrangements, because sometimes, you know, that clearly when there's a child involved, the court is involved as well. And so talking about breastfeeding and the benefit of breastfeeding, your right to breastfeed or provide breast milk. And then the last one is on that hand expression, because again, I really can't emphasize enough, no matter who you are in this process, you have the opportunity to make a really big difference in just teaching one simple thing, and that's hand expression. So if you have the opportunity to speak with someone who's pregnant, my family makes fun of me all the time because we'll like pass a pregnant person and I'll be like, oh, maybe we should talk. They're like, get out of her business. Don't talk to her. But the truth is that it can be a really powerful tool. It's such a simple thing, but we're just not taught it. And so you have that tool now available. And if you have the access to somebody who you think might benefit, you can offer it. So that's it. I'll get off my soapbox about it.
I do the same thing to folks at the supermarket. I'm like, oh, she's pregnant. She probably wants some information. Someone had said something about residential drug treatment, and I wanted to know a little bit more about that statement. So is this information for women to know, even knowing as part of their sentence is going into residential drug treatment? So was that a comment just to note? I wanted to know more about that. Is this a benefit to them to do the lactation? Was that as a part of, you know, like an incentive, or what was that comment from? Because I remember that there were a lot of, okay, to clarify, on behalf of the mother entering the program, what is their process? Leticia, entering the drug program. Oh, that might have been something talked about earlier. Hannah, was that a conversation you guys had earlier about this related to a drug treatment program?
You know, the only thing that comes to mind, Leticia, maybe you're referring to the drug screening that Aditi spoke about when they enter the program, the lactation program. So basically, and Aditi, if you're still here and you want to clarify or say something that's not accurate, please jump in. But basically that, you know, all persons who are pregnant, who have recently had a child, are lactating, should be asked if they want to participate in the lactation program offered by the county jail. And that in that intake process that they will be asked some screening questions around drug use, and that the only purpose of those screening questions are to notify medical staff of additional information that might need to be given for an individual case.
Okay. And I think you may have went over this, but you know, maybe it could be helpful to just offer perspectives around if a person has had drug use history, but obviously in the incarcerated experience is not currently using ideally. Are there concerns around lactation with a history of drug use, and what's the recommendation there?
Yeah, you know, Leticia mentioned, she said, no, it's important to have answers for the mother and how she can continue to be nurturing to her child when in drug treatment. And so, yeah, I do also want, I think I gave you a resource at the very end of the presentation around medications and mother's milk. So Dr. Hale, and really, you know, this is why it's important to be in contact with either a lactation educator, but more a lactation consultant who can really point towards some of these resources. Because when we look at things like methadone treatment and some other drug treatments, we still would like to encourage lactation. And remember that the goal here is for us to be able to support a breastfeeding or a breast milk feeding relationship long-term for the child. So even if there are periods of time whereby we're supporting mom's supply and not delivering milk to baby due to certain medications, that's okay. What we want to do is we want to give the opportunity for the dyad to be able to continue their breastfeeding relationship long-term. But many drugs are compatible with continued breast milk feeding. And we really think about this. This is kind of like a paradigm that we need to step out of in terms of mainstream dominant culture, is that we think of formula feeding as having no risk. But actually, formula feeding has a huge risk to infant, and more often than not, the risk of giving breast milk, even when we're on a medication, is less than the risk of giving formula to an infant. More often than not. That's not in every case. Of course, there are times where it will not be safe depending on what mom has ingested, but more often than not, we're really looking at that risk benefit. And so, yeah, you're absolutely right, Leticia, like we have to be able to educate for mom. And I do believe, not to be just completely optimistic and glass half full, but I do believe that, you know, when we talk about what we look at in terms of nursery programs, and when we give women the opportunity to nurse and be with their children or have a relationship, a continued relationship, we see extremely low recidivism rates, which means that we know that these practices are helping people kind of figure out, like, where do I want to go? How do I want to be and show up for this other human that's now in my life? And so, you know, when we help to continue with supporting lactation, we're helping with that entire journey. It may not just be about that one bottle or those two bottles.
Absolutely. I had a client years ago who had pretty extensive drug use during, you know, her life, and had used some during the pregnancy, and realized she was pregnant late into the pregnancy and was concerned about the impacts on the infant. And one of the things that I was encouraging at that time was, okay, you may not be able to do anything about the fact that you could have exposed your baby to substances during pregnancy, but now that the baby is here, you can do something about making sure that they have the healthiest body possible, and you have access to that. Like if you compromise them in any way, you also have the opportunity to add to them. And so just like offering just that framework of like the reparative opportunity of providing their breast milk can give a lot of purpose, you know, for folks that feel like they have, you know, already messed up so much and they're already going to be unavailable. And I've seen a lot of depression and a lot of a sense of like helplessness around their ability to parent and to be a good mother and to show up with any value for their infants at times because of, you know, the circumstances of their lives and the fact that they're, you know, in the system at this point. And it can be helpful to think that there is a thing I can still do that no one else can do but me. And so I like to encourage that when appropriate and when possible, that kind of, you know, reframing. And hopefully that'll be helpful if it comes up.
Thank you. Judah, if you have your hand raised.
And I'm wondering if you, Judith, tell us if you're having issues unmuting, because someone had said that earlier. I'm wondering if it is set in a way that we can unset.
Oh, that's a good question. I wonder, Aditi, is it possible the settings are such that people can't unmute? I don't think so. Actually, see, Judith,
I don't
muted.
think that's true, but I'll check again.
Judith, you said you are unmuted. Did you have a question or did you accidentally raise your hand?
Can you hear me?
Yeah, now we can hear you.
Oh, okay, yeah, sorry. I'm sorry, I don't know why it's not, I do this all day long on Teams, and I don't know why it's working. So I go by Danielle, and I'm the clinical program director for the Mamas program at Department of Health Services. So what we're trying to do is get, couple of things about drug treatment and women coming out of jail. We are desperately trying to find the women that Dr. Natel and all of you are releasing from jail. Unfortunately, sometimes they get released, on the weekends and evening hours, and we have a hard time finding them. So when we do, a lot of times they're released into drug treatment centers to finish their sentence, which is fantastic because it's usually a residential program, and we have very good relationships with a lot of residential programs. And we work very closely with the Department of Public Health's SAPC program, which funds, like 300 and something drug SUD programs. And so we're trying to find these women. And I just want some of you guys to know, especially the caseworkers, is that depending on where they get sent to for residential, for example, prototypes in Pomona, I mean, I think they're pretty good about helping with, refrigeration, and things like that for breastfeeding. The best thing would be to try to keep the mom and baby together. The best thing would be to have them released into drug treatment already pregnant, so that when they deliver, they can keep the baby. That's what we're really trying to do. But it has been a little bit challenging with interim housing. DT, this might be something you want to take up in the future, is that we've really pushed to have moms who are breastfeeding for them, excuse me, hold on. For the facilities to have a refrigerator. And in the last year or so, one of our moms actually was not able to do that. They couldn't accommodate her. And that was just so frustrating for our staff. And the woman ended up leaving, and it was just like this huge problem. And, they didn't treat her very well because, it was like the one thing that was different than everybody else in the program, right? So if there is some type of like part two to this, it would be to deal with the interim housing and the drug treatment centers to make sure that this goes, in all the amazing work that is going to be done and is being done in the jails can be, followed through to where these women go, because most of not, sometimes they go to the families, sometimes, Lord knows where they are. Believe me, we try to find them. It's really difficult. But I just want you to know that DHS is doing our darndest to find, these women and to support them with breastfeeding. In particular, we've got 4 public health nurses that are all now taking the breastfeeding courses, and they're just really, really into it. So I just wanted to put it out there.
That's amazing. Thank you so much for sharing that information. The continuity of care and services, it's like the ever moving target that, we're just going to all keep wrapping our arms around. So it's a good foresight to be thinking about.
But I mean, if if the staff in the jail really do all of this stuff and make it really common and knowledge, and it can be a fantastic way to empower these women when they do go, you know, to wherever they're going to go, to advocate for themselves and their baby and how important breastfeeding is.
Absolutely.
Thank you so much, Danelle. Yeah, I couldn't agree more. And I think that, you know, to add to some of the education, you know, when we talk about things, sometimes when we talk about lactation or birth, you know, we talk about things in a perfect world, and that's not the world we live in. And so a lot of times we do have to add that piece around its advocacy, but it's also this acceptance of, you know, should I go to a program whereby they don't have a place to store my milk? It is heartbreaking. Anyone who's ever you know, expressed milk and had that bottle spill on the floor or had it go bad, somebody forgot to put it in the refrigerator, knows the heartbreak of the work that it took. And I can only imagine how magnified that is when you're separated from your child and feeling this is the only thing you're contributing at this point in time. However, I think also adding to it, remember that perspective of what we're aiming to do here is to continue this relationship longer past this program, right? Past this time period. So if one bottle or two bottles doesn't get saved, we're going to keep pumping. We're going to keep expressing. We're going to keep our supply up so that there can be that time, hopefully. And that's not going to be in every case, of course. We're not trying to give false hope, but I do think that sometimes that perspective piece is something that can be useful when we're really counseling people. And I love that your public health nurses are trained in this, because what you already know, Danelle, is that so much of this is not about the technical piece. It's about the counseling piece.
Totally agreed. And I just want to thank all of you for all the amazing work that you're doing to make this more than just, oh, we encourage breastfeeding at labor and delivery. You know, I mean, it's just in the hospital. I mean, it's beautiful to see this work happening.
Well, back at you, because we know what kind of work you do. So thank you.
It just has no, go ahead.
Oh, I just also, Hannah, at the very beginning, I think you said the most like poignant thing. I was trying to write it down really quickly, but then I couldn't catch it all. But I think you said the most poignant thing. It's like any amount of breastfeeding is like great, or whatever that quote was that you had, and any amount of baby bonding with the mom is, you know, fantastic. And you know, it's like, and I think if we can get those messages to parents, I mean, I don't know how heartbreaking it would be, you know, I'm sure it would be to still have them separated after a day or two, you know, if they're going back to jail after delivering. But still, it's like, just, wow. Yeah. I mean, I could see where the motivation would be to prevent recidivism if that bonding has occurred. You know what I mean? It's like, wow, what motivation to do what you need to do to get your baby back. And we do help, you know, we do try to help our patients with, you know, reunification as much as possible if the baby's taken away.
Someone's email, just FYI. I don't know if that's intentional. Jacqueline? Oh no, I don't know. Hannah, is that you?
I think
no, it might be Terry.
I think that's Terry Whetstone's email.
Yeah, well,
so
sorry.
I think
no
you
problem.
shared your screen.
What we know about all these screen shares is that everybody's incredibly busy. I think that's my takeaway from the screen shares. DT's calendar was like, I just hope that's never my calendar. But
oh
yeah, your screen
okay.
sharing.
Ooh.
There you go.
Okay.
The conversation about the refrigerators earlier reminded me of a conversation I'd had with one of the facilities years ago, and they were saying it was just, you know, just the glitchiness of the logistics of having, they couldn't use county funding or, you know, public funding to pay for refrigerators for whatever reason. Like it hadn't been approved as an item that should be a taxpayer's cost. And so this was the barrier. They were like, okay, well, we could do all these other things, but we can't provide the refrigerators. And then they had to partner up with an organization that provides the refrigerators for the system. And not that that is anyone's concern, but here per se, but just, you know, the opportunities to just like know all the little glitchy things so that we can think through them as much as possible and communicate with those that are the next pass off folks. And as much as we can be aware of all the parts that are needed, we can also share that information as much as we can with the individuals who are going to also be engaging with these lactating folks, because it is, you know, I know, Hannah, you were saying, you know, it could be something to consider, like not going to a residential location that doesn't have a refrigerator. But I know at times it's not an option for people. Like, it's the one that's available. There's no other bed space. It's how they can get out of prison and go to this facility. And so then, like, what can we do to support that? And if it is that they, for whatever reason, are not interested, activated, funded to do it, how can we find other folks that would be aligned to want to support that, even if it's, and I work in the nonprofit space, you know, foundations that would fund it, or other organizations that could help. And so if we do see barriers, it's encouraging, you know, us to communicate with our peers in this work, you know, and then the greater works, because there are people who are really determined to see access as much as possible, and will put money or time or energy behind it.
This is Janelle again. I'm calling Terry and Patrick out from from LABBN, because I mean, that would be amazing if you guys could figure out some way of providing the funding for, you know, $100 small refrigerator or something to certain places. You know, just something for you guys to chew on for the future. I mean, you're right. I mean, these are where those little needs are important. You know, can the sheriff's department get funding to get a few electric breast pumps? I mean, they're really, in the grand scheme of things, they're not that expensive. You know, can organizations, you know, provide those? It's just very little investment, really, to get this going.
But it does take that communication, you know, thinking collaboratively of like, how can things work? So I know one organization, they have like this robust triage between WIC, who has breastfeeding pumps for folks as a part of their program, and the lactation folks are contracted out with WIC, so that when the individuals come out of the facility, that they're able to go to this to get services from individuals who have this contract with WIC. And so just like there are, you know, ways to strategize it, you know, we have to figure it out locally, but it is possible. So, but definitely when we see the barriers, like as much as possible, if we could just notice them, and, you know, I'm happy to hear any kind of issue that comes up and like help people triage it, because that's what I do with people with their own lives, but also with systems. And you know, Breastfeed LA is also, we're so connected because we're community based to a lot of organizations that you wouldn't necessarily think of in the correctional setting, that are out there that could provide various services. So please don't be shy to reach out to us with questions, with concerns, even if it just seems logistic, like local and practical for your institution. Because, you know, we may have experienced some of the things that have come up, or our partners who are doing this work have. Other thoughts? I'm curious, and you may have mentioned it before, but how long are the birthing people able to stay in the facility, in the hospital, or wherever they're birthing with the baby until they have to return back to the facility? Is it just a 24-hour period? Is it 3 days?
This is nurse practitioner at CRDF. I believe, definitely know it depends on if they had a vaginal delivery or a C-section. Usually, for vaginal deliveries, they have, I believe, like 24 hours after delivery. So the third day they're brought back. And then for C-section, I think they're at the hospital up to like 4 days, and then they return back to the facility.
Do you find that people try to schedule a C-section to have more time with their babies? That's common in a lot of facilities around the nation.
So around that, so where we're located here in Linwood, the two closest facilities are Francis and King. So if it's not scheduled, they'll go there. And because we're not contracted with them to actually help manage their care or get any communication to those facilities, with Dr. Natel and I, we counsel them and talk to them about their plan. What would they like to see at delivery? Do they want their family there? And if they do, we encourage an induction. And so that way we're able to schedule it, and they can be transferred to LCMC the day before their delivery date, and it can be coordinated in that manner. So
yeah,
we do that to help them have some sense of control over their situation and autonomy, and find that useful.
I know it's such a challenge, and I've seen this. I mean, it's this real life, practical, very niche to circumstance where people have no control over anything in their lives. And this is like a one area where they really want to know that they're going to have time or a person there. One of the things that is just important to know, and Hannah, I'd love for you to talk about this if you hadn't already, is just, induction and C-sections both are a bit contraindicated to really successful breastfeeding. And certainly you can breastfeed and lactate after both. But it does create additional challenges with that. And in general, it creates, higher risk. Induction creates higher risk for C-section. C-section, can create risk for other complications. And obviously then you're recovering from a surgery. And so you get to have more time with your baby and then more time in a facility recovering from a major surgery. And so it's a battle, and it's a battle that I know folks have with themselves and facilities have. But I think sometimes without having all the information about some of the challenges and the risks to that, or the benefits and the pros and the cons, even for them to make, the most informed decision for themselves around, what to consider other than just that you want to be able to control the timing. But it is such a niche situation that people end up saying, I'm going to prioritize that, and I'll let the chips fall where they may, because I want to know that my partner is going to be here or my mom can come. But that's also then an opportunity for us as systems to come up with ways that we can mitigate that. Like in the regular world, we mitigate that. People have no idea when they're going to have their baby and their family's there, right? And so how do we do that? We'd have to have ample communication. There'd have to be, an emergency or triage or urgent, response call plan, which is difficult when people don't have access to a phone that they can just use themselves, right? So I know, like, inside, the barriers are who are the people who are going to make that call for them, or how are they going to get access to let their family know that it seems like they're going into labor. I mean, labor tends to not be an immediate process where you just pop the baby out all at once. You might have been having some labor contractions, and families could have been communicated with sometime in the day saying, hey, you're going to get a call at some point. Ideally show up at the hospital within a couple hours when you get the call saying that I arrived there. So, I just want to encourage us to keep thinking in the ways that really offer the most access and options, as possible, because it's not without a downside to just scheduling inductions and C-sections, which I know is not necessarily just on the facility. It's obviously the person's choice. But just thinking about ways to make it so that they really have the options that we would have in this sense, in the situation that they're in. But it's hard.
Yeah, I agree with everything you just mentioned. I mean, it just becomes really difficult, and I think I've tried to express to, like, even the medical higher ups, like Dr. Henderson, who's over the whole corrections here, and then even some meetings with custody and stuff, or even with the hospitals. I'm sorry, with King and Francis, so that we could have a mutual contact person to communicate. but we don't have any of that. And then, it's just the logistics of that. If without it being scheduled, it gets to be really, really difficult. And then sometimes I think Francis just went through a management or ownership change. So the nursing staff they're probably stressed out, so I'll give them a pass, but they're not very friendly or even flexible to help with, managing the care once they're there. It's like, it just becomes difficult because we are still responsible for the patient.
Absolutely. And so as much as possible, and of course, it's like, I know those barriers, like I know them, and, just, all of us in every way we can have to just keep pushing. It's so, nobody else can fight for them for that but us. Like they can't on their own make the system, make that higher up person know that you have to assign a person to be the communication. Like they have, let's say if we, the right to have support of their family, and that they have, this is just like if there was a safety issue that we wouldn't put aside for any reason, no matter how much it inconveniences the situation. There are things that the systems have just allowed, and this tends to be also a gendered thing as well. Like, oh, I know it'd be nice to have somebody, but you could work it out. It's like, but it really is, a very monumental life experience for a person when they're birthing, and then obviously for the infant. And as much as possible, the systems, we should, not that we are not, we're here, but the system should hold to that. And every time we get comfortable with something that the birthing person, which is in the general system, even outside of incarceration, or, the incarcerated person, sort of, well, sorry, that doesn't work out for you. It's what happens when you go to prison. If it gets to that space, we have to just keep pushing. It's like, no, that's not okay. We're not, and who has to be the next person? And sometimes it has to be outside of the facility. There's a lot of politics in corrections, and people have their job and their safety. Hospitals have their job and their sense of security and all that, and not security, but not wanting to push back on things or not wanting to make things more difficult than it needs to be. But of all people who really need the support, these people need the support. They need people to try in every way to make it as natural as possible, not natural birth, but just as holistic and cared as possible, because at the end of the day, everybody else is going home to their family and they're going back to the prison, and that baby's going with another person. And that in and of itself should be the only thing that they have to contend with. And I know that we can't control all those factors, but when they come up, just encouraging us to keep pushing against it as much as possible. And thank you for all the work that I'm sure you're doing to try to get people to see that perspective, because I could hear that you're aware of that.
Thank you.
And I just want to highlight here, out of many of your control, but Aditi had mentioned with the law that passed recently this year about a support person, requiring that a support person be available. And, a lot of what Dr. Pepra was talking about around the risk to initiating breastfeeding and the risk to lactation with induction and cesarean section, a doula is not the answer to all things, but having an advocate, someone particularly who is knowledgeable or trained in the management of early lactation by someone's bedside throughout the process is going to be extremely beneficial in mitigating some of the negative effects that we can see from both those methods of delivery when those methods are either chosen or unavoidable. So certainly focusing on, if you have it in your capacity to jump on. I know that there is already a lot of talk with the AIM doulas and Dr. Nattel and other people who are coming together to figure out what this looks like for LA County. So if it's a passion project of yours, I know these conversations are happening. And I think that just to highlight what Saida mentioned is that, a lot of times it just takes that communication that Nurse Hill emailing me and saying, I know this sounds crazy, but we need 100 pumps. Any chance you have them? And you never know. I might just have them. And so really reaching out to our proverbial village to figure out how we can better support each other in this work. Saida, I don't know if there are ways that you want to close us out here, but we are at noon, so I just want to be cognizant of everyone's time.
Absolutely. And that last thing you said just reminded me too, considering all the logistics and the challenges with communications inside and between these systems that have their own operations, the community-based organizations a lot of times can hold some of those communications. So really thinking about some of that is an opportunity to just have one person call one person and that person deals with all those other things, and that being what you need, right? And saying, you know what, there is no one we could designate to do this because we're responding to things that are happening inside of our facility, and we can't really know that person would be available. Just whatever the need is, it could also be tossed up to, we need a whole organization or individual to hold this, and maybe needs to be outside of the facility. And then of course in tandem and communication. I'm really excited about the opportunity for all of us to have had conversations today. It matters that each of you do what you do, and ultimately, for society and for all these babies, with mothers who are incarcerated and all the individuals that'll go back into the community at some point one day. What we're doing here makes such a difference for them, pregnant and postpartum and all that now, but also those that are coming for the future, because we're like creating a new path. And so just encouraging everybody to keep the motivation and the momentum. And sometimes that means having conversations with people outside of our environments who are feeling more motivated and hopeful because they see the possibility in ways that it's hard to see when you're inside. I'm going to leave my email as well in case something comes up and you feel like you want to contact me directly. And we thank you so much for your time and spending with us.
Thank you, everyone. Thank you so much for being here. And it's not said enough in public health and in the services, but we appreciate you. So thank you. And we will leave our contact information. Please, please feel free to reach out. We will look forward to it.
Thank you for a great presentation.
Thank you. This is Practitioner Harris at CRDF. Just want to make sure if you could, I was only able to do audio only, so you're going to email those PowerPoints, correct? I think you mentioned that.
Absolutely. Yeah, I'll email PowerPoints. We're going to email some handouts to you, and I'll include contact information in there as well.
Awesome. Thank you so much.
You're welcome.